Morning, good afternoon, and good evening to all, depending on your time zone. In the next 10 minutes, I will be discussing scaling up testing for COVID-19 and hepatitis, the Africa perspective. My name is Mohammed Abdulaziz, and I am the head of Disease Control and Prevention of Africa Center for Disease Control and Prevention. Before the onset of COVID-19 on the continent, Africa CDC conducted a desk review of the challenges of laboratory testing with a view of setting up innovative and targeted interventions to improve laboratory public health systems on the continent. The challenges we saw included under-resourced infrastructure and equipment, and where these are available, they generally lack maintenance culture. Often the laboratory services do not guide clinical decision-making. This has been attributed to high costs, leading to low demand for testing and suboptimal utilization of modern diagnostics. Other challenges include poor laboratory control, quality control and assurance, with lack of credible accreditation process, paucity of leadership to provide adequate policy interventions, technical guidance and supportive supervision, and inadequate or absent national and regional laboratory networks. To address some of these challenges, pre-COVID pandemic, of course, Africa CDC piloted an innovative regional approach to strengthening laboratory public health system in Central Africa, which we call Regional Integrated Surveillance and Laboratory Network, RISNET. This involved selecting 7 laboratories from across the region and mentoring them towards ISO 15189 accreditation. We trained the staffs of these selected laboratories in WHO strengthening laboratory management towards accreditation and stepwise laboratory improvement process towards accreditation. They were further trained on quality assurance and external quality assessments and basic laboratory information systems. Other training are shown on your screen. We also began the process of supporting the countries in completing their national laboratory strategic planning. This slide shows the capacity building activities of Africa CDC after the COVID-19 pandemic hits the shores of the continent. In January 2020, no African country could make the diagnosis of COVID-19. By February, Senegal and South Africa were the only 2 countries that acquired the capabilities of COVID-19 testing. Then Africa CDC intervened by conducting 2 sets of face-to-face training for over 50 member states in Senegal and South Africa, and countless online training that resulted in all the 55 member states of the African Union having the testing capacity for COVID-19. Out of the 12 million tests conducted in Africa by August 2020, Africa CDC supplied 5 million of such tests, bundled with extraction kits and viral transport medium. We continue to support member states in stepping down the testing to do more peripheral labs and using point-of-care testing such as GeneXpert, and very soon we will be introducing antigen-based testing. Africa CDC is also building sequencing capacity of public health laboratories in 6 countries across the continent, as shown on the map on your screen. To ensure African countries do not run out of critical logistics supplies, Africa CDC set up the Africa Medical Supply Platform, a single online marketplace to enable the supply of COVID-19 related critical medical equipment, including laboratory consumables. It was developed under the leadership of Strive Masewa, the AU Special Envoy, on behalf of the Africa CDC and in partnership with many other partners. At the end of COVID-19, this platform will be available for laboratory supply for programs like the hepatitis elimination. This slide shows the cumulative testing conducted on the African continent from 14 February to 14 September. It shows that when Africa CDC rolled out the Partnership for Accelerating COVID Testing on the 4th of June, only 2.5 million tests have been conducted. 3 months later, the continent had conducted a total of 13 million tests. The Partnership to Accelerate COVID-19 Testing in Africa, PAT strategy, surpassed the targeted 10 million tests 2 months ahead of the targeted dates of November. Half of the tests were facilitated by Africa CDC, and the target is now 20 million tests by the end of October 2020. Currently, the two-step testing for hepatitis C is less than adequate for scaling up services, and a more effective point-of-care testing is needed, one of the biggest challenges to hepatitis testing on the continent. There is lack of regional and national testing policies and redundancy in testing capacity due to parallel programs. We need a hepatitis C point-of-care viral testing costing less than $2 United States. Investment in point-of-care testing for decentralization of testing to more peripheral clinics and sites played a very crucial role in scaling up testing for COVID-19, and we think it can do that also for hepatitis elimination program. Continental and regional guidance on testing policies to be implemented at country level was done for COVID-19 could also play a very useful role for hepatitis elimination, where we will be able to insert standardized testing policies into the national laboratory strategic plan of countries. We need to rethink unilateral programs to remove barriers that creates redundancy. It is not acceptable that some programs have 50% of their gene expert machine being redundant and the time it is needed by other programs. And a good example in Nigeria, where they use the gene expert machine for TB and the research and some research laboratories and even university PCR machine for COVID to quickly accelerate COVID testing. The use of trained community health workers is useful, as has been shown in the response to COVID-19, for data entry for testing. And this could help improve the data quality for hepatitis elimination program. Pool purchasing of laboratory consumables through regional and continental mechanism was used by Africa in to respond to COVID-19. And this can also be used for hepatitis elimination. We've seen good example with the African Medicine Supply Platform on Gavi, in which it was used to increase the volume of testing and also reduce the cost of those consumables. Investment in research for an efficient and more cost-effective point-of-care testing will be very useful, as has been shown for COVID-19, in which we now are hoping that in the next few days we will be having antigen-based tests that are very effective for use. So what are the takeaways? COVID-19 pandemic provided the will and pathway to an unprecedented scaling up of laboratory testing on the continent. This we can use for other programs like hepatitis elimination. Lessons from response to the pandemic can be used to improve and fast-track high-impact public health programs like the hepatitis elimination, and then continental and regional approach to laboratory supply chains and logistics, as shown by the African Medicine Supply Platform, could rapidly scale up testing and also bring down the cost. Breaking up silos program can reduce redundancy in the use of public health assets for impactful reduction in mortality and mobility from infectious diseases like hepatitis. Thank you very much for listening, and I will be happy to take your questions.